Welcome to this video, and I am so pleased to welcome Professor David Nutt. Professor, thank you so much for coming.
It's been a pleasure, John. So far, anyway. Let's see how it goes.
Yeah, we'll see. Now, I became a registered psychiatric nurse a few weeks after my 21st birthday.
Oh, wow.
Things went a bit sideways after that, but that's what I did when I was 18, 19 and 20. So, pretty happy memories, really, for most of it. But you're a doctor, you're a psychiatrist, you're a professor, you're an academic, you're a writer, and you're, to be quite blunt about it, a world-leading expert in psychopharmacology. So tell us a little bit about yourself that you think might be relevant, and what the heck is psychopharmacology anyway?
Well, it's a word you've already mastered, which I'm impressed with. But then that's psychiatric training.
Yeah.
As a
if you learn when you're young.
Yes, quite. So psychopharmacology is the study of drugs, how drugs affect the brain and mind, and I got interested in it really almost from my very first day at university. I actually went to university. I thought I was going to do physiology, and I was going to work out new ways of treating pain using improvements on electrical stimulation. But my mentor at the university at Cambridge was a guy. He was the guy that discovered GABA in the brain.
Right.
And it was at the time when we were rewriting the whole science of the brain from essentially being a telephone exchange where everything was electrical to being some sort of soup of chemicals which somehow pulled things together. He discovered GABA, and the concept of synaptic transmission and neurotransmitters was just developing. And then, of course, given the fact that the brain works through utilizing maybe up to 80 different neurotransmitters, to understand those, you have to use small molecules we call drugs. So then I got interested in drugs, and I haven't solved it all yet, so I can't take it. I've been doing it. It's a massive task, but obviously mental illness, it affects addiction, and it affects other areas, like enhancement and well-being, etc.
The brain and the mind, it's just so ludicrous, isn't it? I've been thinking about it since I was 18, as you have, and the analogies that are used are often those of the technology of the day. So sometimes it's a telephone exchange, then it became a digital computer, then it became some quantum machine or other. But it's just utterly unbelievable, the sheer complexity of it. I don't know, 100,000 million nerve cells with hundreds of interconnections each.
Well, yes, I think the current estimate is about 80 billion.
Yeah,
and each one's like a little computer, but it's the analogy of the brain really is not a computer analogy. Its analogy is with humankind. It's the brain is so powerful because, in the same way as humans, we're powerful because if we work together, we can be extraordinarily powerful, and we have the technology anyway.
If we could, and in a sense, many aspects of humanity emerge from the brain. This emergent consciousness that comes from presumably comes from the brain.
I don't think there's any doubt about that. We don't understand it. I'm sure. I think. I mean, obviously, there are people who think it comes from elsewhere, and there's no way you could ever say no. But I think it's quite likely, unless we're part of some very sophisticated game that someone beyond the universe is playing. I think it's probably coming from the brain.
Well, one thing I'm pretty sure about having worked with anaesthetists is we can switch it off for a period of time. That seems pretty convincing evidence, actually.
Well, that is also true. Yeah, but what's interesting, of course, John, we'll come on to this later, is that until recently, the theory of consciousness was you can switch it on or off. It's whether you are awake or asleep. Now, of course, we've got these wonderful new drugs called psychedelics, which just change the direction of consciousness, as opposed to whether there's a lot of it or not so much of it.
On the topic, I have just finished reading your book.
Fantastic.
Eminently readable, I must say. If you're, whatever you're, for nurses and doctors, fine. For bricklayers, painters and decorators, also fine. Eminently readable and in clear English.
Thank you.
And I must say, I've been looking forward to this because my understanding of psychedelics is very primitive, and I'm hoping you're going to clarify that. But just before we go on to that, what common psychiatric disorders do you come across as a psychiatrist? What causes this mental distress that seems so prevalent in our world at the moment?
Well, yeah, I think it's important, John, when you were doing psychiatry, you were, I presume, in hospital, were you?
Yeah, it was a proper old-fashioned asylum. It was the end of the asylum days.
Where was that?
Yeah, it was Garland's in Carlisle, Cumbria.
Oh, okay.
I strongly suspect you've never heard of it.
I've not heard of it. You're quite right. I've not heard of it.
Yeah.
But there were. I've been in many like that, of course.
Yeah, for sure.
Mostly gone. But there, you were seeing people within, often very enduring and very complex and very distressing, serious mental disorders, and for which we had little in the way of treatments, and today we still have limited treatments. But then there's the much bigger. That's like the tip of the iceberg. Underneath, there's as you point out, this distress and misery and unhappiness, which is becoming in some ways more pervasive, and that's whether it's useful to talk about it as mental illness or whether we should talk about it in some other way, I think is a bit of an open question. It's certainly something we need to think about and try to help people with, but I'm not sure labelling it mental illness is necessarily going to help us, because then it kind of constrains a little bit. If it's illness, you've got to have a treatment, whereas you and I, of course, we definitely want prevention if we could.
Mm-hmm. Well, I don't think there's anyone watching this video who's not suffered periods of whatever we want to call it, mental suffering,
exactly,
psychological distress,
yes,
or close family members who've been through really difficult times, and of course we can't really separate in some respects different parts of the body. The mind and the body are so interrelated. If you're suffering physically, you're going to be suffering mentally as well. That's a component of the pain and of the suffering.
Well, you and I know that. Unfortunately, sadly, a lot of doctors don't, and that's one of the things. They still make fun of us doctors. They make fun of us psychiatrists. They don't know what we do. They think we're.
Oh, you're just a doctor who's scared of blood.
Well, sometimes sometimes we're the thought police, sometimes we're shrinks.
Yeah.
There's but on a serious note, the point you were making is that a lot of doctors, either through ignorance or even sometimes even kind of malice, don't want to think about the psychological constructs. They and that's actually can I be honest with you? That's why I started off being a neurologist. Mm-hmm. Because I thought, that A, it was difficult, and B, it was a real challenge to understand the brain. And then I realised that I worked on what we would call a sort of tertiary third level neurology unit in St Mary's Hospital, and there were people there with very serious neurological disorders, but they were all very similar to each other. Epilepsy, we couldn't do much about it. Multiple sclerosis, we couldn't do anything about it. But the people that we could do things about were the people who came in who had psychological distress, and that psychological distress had manifested itself in things like blindness or paralysis, or other unsteadiness. And then what would happen, and would be that the neurologist would work out, this is not a neurological problem. Leave the ward, and I.
Yeah.
Hang on. This is still a problem. But, it's a problem and people need help. But B, that's actually very interesting, isn't it? Because if someone can be paralyzed from the waist down because their mind makes them, wow, that tells you something way more about the brain than you guys can tell me about when you just have a lump in there. It made me realize that the brain's way more powerful than even neurologists give it credit for.
And I can really relate to what you're saying. We get patients in, I worked in intensive care for a period of time, patients in with overdoses. Yeah. And basically the aim was to get them out as soon as possible.
Yes.
There was no holism, no why did they come here in the first place. And
no.
I think to the list of problematic doctors, we could probably add politicians, but we might talk about that. We might talk about that later if you'd like to.
Yeah, well... I'm just getting. Let's not ruin the conversation to start.
No, let's keep the mind clear. So I think were you talking about conditions there that are hysterical conditions?
Yes, that's what we
That's
would.
the way I'd understand that.
But that's what we would call them.
Yeah.
But just to be absolutely clear, that's an utterly pejorative term. Hysteria comes from, I think, the Greek word for the womb. So hysteria was things that women had. Well, how insulting is that? I mean, how utterly insulting is that?
Well, it's caused by the floating uterus, wasn't it?
That's right, exactly.
Yeah.
Wandering womb.
Yeah.
Men couldn't have it. I mean, well, as well as utterly insulting to women, but also
Totally.
now we call them conversion disorders, and well, I suspect we've all had minor elements of that. Can I give you an example?
Please.
So I broke my ankle really quite badly 7 weeks ago, and it's still not healed. Luckily I'm sitting, not talking, not standing. And what it did several things to me. The first is my blood pressure went up 20 millimeters systolic. My sleep was disrupted by the pain. But now, and I found this the other day when I was in a conference talking with people about pain syndromes, when people talked about their pain, I got pain in my body, not just in my ankle. I'm thinking, this is fascinating. I'm empathizing with their pain, but I'm more able to do it now because I'm in pain myself, which to me very, very. I've been a doctor for 50 years. That was the first time I personally experienced what it is like to have that body response to someone else's pain, and it made me feel quite humble and made me think a bit more about what we should be training doctors to be sympathetic about, because you could if I went to a doctor, they say, well, that's just in your mind, but it is in my mind, but it's come from the fact that I did have a physical problem in my leg and still do.
Well, it's the interaction of the mind and the body, and the experience is real. It's a genuine pain.
Dissociating them is one of the big problems we have in science and in medicine. Is it so much of the way we think about everything is in terms of what the words mean. We use language. It's often very imprecise language. It often locks people into a way of thinking which isn't, is constrained and possibly wrong. And that is really, the idea, there's a mind and not a body, and they're separate. I mean, it's utterly ridiculous. We've got to be much more holistic.
Yeah. So coming back to medications, what has been the main development in psychiatric medications, say since the Second World War? I mean, I seem to remember drugs like chlorpromazine, the major tranquilizers, came in probably about 1957, late 50s.
Yes, that's right.
And then tricyclic antidepressants.
Well, yeah, I mean, the sad truth is that in the 50s, modern therapeutic psychopharmacology, the modern medicines of psychiatry were discovered by accident.
Yeah.
And they were drugs like chlorpromazine, which were made to be sedatives, but did turn out to have some antipsychotic effects. And then there was the first antidepressants, which imipramine was actually made to be a better chlorpromazine, but it had no antipsychotic effect, but it did have an antidepressant effect. And then alongside that came the benzodiazepines as sort of sedative tranquilizers. They're all discovered completely accidentally and then made available as medicines. And then certainly for the antidepressants, significant side effects of toxicity emerged, and so people began to refine them and get rid of the toxic elements. But today, if I was still writing prescriptions, which I'm not anymore, but if I was, I would be writing prescriptions for the same class of drug as I wrote my very first prescriptions back when I first started prescribing in 1972. And no other branch of medicine really are you relying on medicines which have got, are that old and have that, not been improved in that time.
Yeah, it seems to me the changes are incremental. So we went from the tricyclic, sort of fairly non-specific drugs to the selective serotonin reuptake inhibitors. So it's kind of a bit of a tweak, really.
Yes.
We went from phenothiazine antipsychotics to slightly more refined antipsychotics, but my understanding is they work in essentially the same way. Is that correct?
They all work the same. In fact, in some ways, we went to less refined ones, but we went through a cycle of refining and then de-refining because the refined ones had more side effects in the.
Well, of course, it's very important to keep drugs in patent so the pharmaceutical industry can make
Well, that
money
is
from patented drugs.
Yeah, I mean the Me Too concept has really dominated the whole psychiatric development field, and it is partly that the system is very much it very much favours that because once one has got on the market, you know exactly what trials to do to replicate. So you just basically just handle turning, do the same thing. But I mean, to be fair, it's also been that even if you were to invent these medicines currently are quite inexpensive, so there's very little incentive to come up with new treatments. And I mean, in fact, that's the point I've been making recently, that without any incentive, no one will. So if the model is that companies need to make money making drugs for mental illness, and the companies are not going to make money so they're not investing, we've got to do something differently, which is why we've got to look to other lines of evidence, particularly in relation to things like psychedelics, where the evidence base is enormous, but there isn't particularly a commercial way of developing it. So let's do it differently. Let society.
We need a bit of a breakthrough, don't we? I think that Me Too thing maybe got a few meanings these days. I think what you mean in that context is you have a drug like SSRIs,
yes,
and you start off with Prozac, and then you get citalopram, and then you jiggle the molecule, and you come up with sertraline, and you just maybe tweak the molecule just a little bit and call it something new.
Yeah, but they all work in exactly the same way.
Yeah.
I mean, they have some differences, but they're not very much, as you say, incremental advances. And it's also, they've been very successful, and companies have made quite a lot of money out of them. So it's been difficult to persuade investors to do something different. Why? I mean, to the absurd situation now, John. This is kind of fascinating. But there is one company now that is remaking a drug which is 50 years old.
Yeah.
It's a kind of benzodiazepine.
Yeah.
And obviously, it's been used in France for 50 years, and it's pretty safe and quite well tolerated. But obviously, they can't patent that. So they're making they're taking some of the hydrogen molecules out and putting a heavy hydrogen called deuterium. So they're making a deuterated version of this molecule now because they can get a patent. And you think, well, guys, we've got a powerful. If this drug is good, which it might be, I've never used it as a French drug. Why don't we just make it available very cheaply for everyone, rather than make a version just simply so you can sell it? I mean, medicine is just, the profiteering in medicine has distorted logic. Surely we should be putting our knowledge to making something new rather than a version of a 50-year-old drug.
Deuterium's heavy water, isn't it? You remember the heroes of Telemark and all that, those stories from the Second World War of the heavy water.
It's not radioactive, just so we can reassure people.
I'm slightly reassured. So I can remember as a child, hippies, and there was a lot of talk about LSD and various psychedelics, but then it seemed to go really fairly quiet. I mean, I was born in 57, so I'm probably talking about the 60s. I had this peripheral awareness of this. And looking back, well, being reminded from your book, there was some pretty successful psychedelics being used in psychiatry in the late 40s, early 50s. Certainly a lot in the late 50s.
In the late 50s, yes. I mean, I think it was about 53 that Sandow made available LSD for research, particularly in psychiatry. And I think in 57, the famed man Albert Hoffman, who discovered LSD, he made LSD. He then got access to magic mushrooms, and then worked out that the active ingredient in magic mushrooms was called psilocybin. And Sandow made that available. It was called indocybin. So there were basically two medicines. LSD was called Delicid, and psilocybin was called indocybin. And they made it available to researchers in most Western countries, in fact. And in those days, there weren't any psychiatric treatments. The drugs you mentioned earlier, chlorpromazine, wasn't really being rolled out to the late 50s, and imipramine and antidepressants later. So these drugs were the first true treatments in psychiatry, and psychiatrists thought they were really very, very powerful and effective. But then they moved out of medicine into what you alluded to, sort of became part of the hippie culture. And the hippie culture was anti the Vietnam War. And the American government was very pro the Vietnam War. And when hippies were putting up placards saying, drop acid, not bombs, that was seen as a terrifying threat to the US establishment. And they couldn't ban protests, but they could ban the drugs. So they banned the drug. They banned LSD. And then he thought, well, there's other drugs like LSD, psilocybin, DMT, we'll ban those. So even though there was no suggestion that these were about either harmful or even fueling protests. So the drugs got banned by the US in 1968. We followed suit, as we always do, when the Americans say, jump, you say, how high, sir? And then in 71, the UN banned them. And they're still banned. They've been banned ever since. Yeah. It's impossible to work with them. And I think that's the worst censorship of research and clinical therapy in the history of the world. 55 years, drugs which could transform people's lives for depression, PTSD, addictions, they've been banned simply because the American government thought they were actually fueling an anti-war protest.
Our generation, isn't it?
Yes.
You think of the mental distress I've had in times in my life. Could that have been attenuated, ameliorated? Mental distress I've seen in those around me.
Very likely, John. I think that's a very important point to make. That I'll make it in slightly different ways. But it wasn't just that these drugs were the first psychiatric medicines. They were also powerful and enduring. So, you didn't need many, 1 or 2 trips could give you a very, very long-lasting effect, maybe a lifetime. And then, of course, there's the other ways of using them. So Hoffman lived to 102, and he used what we would call a sort of mini or a microdose of LSD on a regular basis to keep his brain active and functioning. And the first British psychiatrist to use LSD was a man called Joel Elkes. He was professor in Birmingham in 1953. And he took LSD and he wrote about the experience and said, I think I know how it works. And he lived to 103. So it's quite possible that if we use these drugs sensibly like the early guys did, they could have given us resilience and longevity too, as well as help treating mental illness.
Yeah. What are the main... what is how do we define the term psychedelic? Has it got a precise meaning or is it?
So the term psychedelic, there was a lot of debate obviously the famous the writer who made the term psychedelics known, and he helped coin the term. It wasn't his term though, actually, was obviously Aldous Huxley, and he and a guy called Humphrey Osmond. Humphrey Osmond was a British psychiatrist who couldn't get a job in Britain, or at least couldn't get a job that paid well enough. So he went off to I think Winnipeg, in the middle of the Canadian plains, where they were desperate for British doctors. But he started using LSD as a treatment, and he was the person who actually gave LSD to Huxley, because Huxley's first writings actually, from mescaline, not from LSD, which is a cactus derived. Yeah. And what are we going to call this? And I think Huxley said, what about enthymome or something? I don't even know how to say it. I think Osmond said, no, that's not going to catch on. And he said, what about this word psychedelic, from the Greek mind manifesting, and that's what's a psychedelic? Something that helps you understand your mind better.
So the particular compounds, we've mentioned psilocybin, that's from mushrooms. We've mentioned LSD, lysergic acid,
yes.
Ethylamide. That's purely chemically synthesized, isn't it?
Not originally, no.
Oh, right, okay.
So Hoffman, here's a tale. This actually, many of your listeners may not know this. So nature makes a thing called lysergic acid, right?
I didn't know that. Right.
Various fungi make lysergic acid. The ancient Greeks knew about it. The ancient Greeks knew that when ergot, the fungus, grew on the cereal crops. In fact, the ancient Greeks thought the main purpose of cereals was not to make bread, but to eventually in autumn, when you had dew, the fungus would grow, and they see these black things growing. Great, that's now the rye has matured. They take the ergot, dissolve it in wine, and make a drink called the Kikion, which is a kind of psychedelic drink, and they love that. It fueled many of their celebrations, which were called the Eleusinian Mysteries, for about 1500 years. In fact, they were so popular that the Romans, when they took over Greece, thought the high level Romans said, we like this too. So the Romans allowed them to carry on because the Romans just took part in it. It was part of a festival. Mm-hmm. Anyway, but then in medieval times, people still knew there was a value, even though they weren't making the drink. There was a value to ergot, and the knowledge of ergot was held by women because they knew that ergot, which contains lysergic acid and other ergots called ergotamine, could be used to help women stop bleeding after they're given birth. It constricts the uterus. And we still use it today for that effect. And so these women were using ergot, but people knew that ergot itself could be slightly psychedelic or hallucinogenic. And that's one of the reasons women got persecuted, because they were using these slightly hallucinogenic substances. They were treated as witches and then persecuted. My own view is it was actually a significant desire by the male medics to eliminate competition and to actually, as part of the usual hostility to women. But ergotamine still exists. And what happened, what Hoffman and his boss, they worked out what ergot was. They got the chemical structure, then they worked out how to use it and make molecules. And then what Hoffman was trying to do was make a version of ergotamine or lysergic acid, which you couldn't patent because they were known. He was trying to make, as most drug companies have done ever since they took willow bark and turned it into aspirin, take a natural molecule, make a conversion, patent it, make lots of money. And intriguingly, I suppose thankfully, he discovered when he took the lysergic acid and put on these couple of ethyl groups to an amide link, it was very different to anything he tried before, and so that's how LSD was discovered. Yeah.
Interesting.
So you can make it from natural products, adding those diethylamides, or I don't know whether they make it purely synthetically. I don't know.
Mm. But it's copying nature, isn't it? It's copying natural molecules.
Yes, that's one of the ways we often describe this new field of medicine. It's sort of plant-based or natural medicines as opposed to synthetic medicine. But John, just to be so you have to be clear, the regulations make it virtually impossible. We could not study natural mushrooms or natural DMT. The current regulations make it virtually impossible for us to study those natural products in the UK because everyone's so obsessed with purity rather than value. Well, the regulators are anyway.
Yeah, that's interesting. This is the sort of dichotomy, as it were, between pharmaceuticals and herbalism, isn't it? In pharmacy, you aim for one molecule of a very precise known amount with a very precise defined purity and structure, which is fine. But in herbalism, you've got a wide variety of molecules that might interact, that might inhibit, that might synergize, that might potentiate.
Exactly.
It's harder to control the dose. But I have come across people locally who actually have acquired quite a high level of expertise in psychedelic mushrooms. They are aware that you can dry it, that you can wear it out. Weigh it out. They know the effect a particular dose will have, exactly. And it does seem to have a level of predictability. Now, of course, we're not condoning that. That's illegal. These are Class A drugs at the moment. But surely you're one of you are the most senior psychopharmacologist in the country, a very experienced psychiatrist. Obviously, you can prescribe whatever you like.
Well, obviously I can. The reality,
or does the nanny state get in the way?
Well, I mean, the worst, as I said, the worst example of censorship of medicine is the censorship of psychedelics, because when they were banned. I mean, it was cynical and cruel.
Yeah.
The ban wasn't just to stop people taking it recreationally and protesting the war. They said that they were banned because they were very dangerous, and So they were put into Schedule 1 of the British and UN conventions. And Schedule 1 says no medical value, which was absolutely, I mean, the 1,000 papers, no medical value because we don't want it to be medical value. They said they were very dangerous when, you got 40,000 patients have been treated. I mean, as far as we saw, very few harms. In fact, remarkably, even in people who have disorders that we today wouldn't try them in, people with psychosis, they didn't seem to cause a lot of harm, and they were addictive when there were papers published and they were anti-addictive. So this was basically just complete dishonesty. They were trying to, I think, they thought these drugs were so politically challenging, they wanted to eliminate all knowledge of them, and they almost succeeded. In the 60s, the 70s and 80s, there was almost no publications on these drugs, but then now my group and others have started to bring them back, partly because of the reasons we've got no innovation, and partly because the science of them is so fascinating, because they do reveal the mind as well, and the brain as well as the mind, when you do studies on them.
Yeah, it just makes it so interesting. But from a practical point of view, if you want to conduct a trial and you want to, say, give someone a particular dose of psilocybin,
yeah,
where do you get that psilocybin from?
Yes, well, generally we get it. There are two. You either get it from companies that are making it as a medicine, which they're trying to get a license for, or you can. There are one or two other companies now in Canada that have been set up to make it available for research, so we can buy it from them. Right. But it's an unbelievable process, because getting this super dangerous drug, Schedule 1 drug, from Canada to Britain. I mean, it's easier to import plutonium. It genuinely is almost, it takes a year basically to get it. I mean, it's just, there's so much paperwork. They don't want it. Yeah.
I actually find it offensive that, a doctor with your level of experience has to spend so much time filling out forms rather than looking after sick people. When I'm ill, I want someone like you to look after me, please. I don't want you stuck away in an office doing some stuffy paperwork, jumping through some silly hoops. But I think you do spend quite a lot of time doing that.
Oh yeah, it's utterly distracting. Here's
I don't know how you keep going. It must be soul destroying.
Well, yeah, someone's got to do it, haven't they, John? I mean, I think the truth is, it's being sacked. When I was the government's chief drugs advisor, being sacked actually kind of made me realise it. I tried reason. I tried 9 years of reason before they sacked me, and I realised reason isn't going to work. So you just have to get around it. So
I mean, you were what we call the UK drugs czar, for want of a better term. You were
that's right, yes,
the go-to, but then a particular prime minister. 2009.
That's right. Yes, Gordon Brown and I never really saw eye to eye.
Yeah, decided that they didn't like your science, so you got.
Yes, I got the boot.
Sacked isn't too strong a word, is it?
Oh no, it was an absolute sacking. No, there was no question. Well, you might find this amusing. I won't tell you the whole story, but one afternoon I got an email asking me to resign. And I said, well, why should I resign? All I've done is done science and told you the truth. And I'm not going to resign. And then the email came back, well, you're sacked then.
Yeah.
Can I just finish the story about the first?
Please do.
So in 2012, the Medical Research Council put out a call for new treatments for resistant depression, accepting the fact that we hadn't any. And we wrote this grant suggesting that psilocybin might work. And the reason we thought it might work was because we'd done the brain scanning studies, and we showed it changed activity in the brains of in the same places as depression was cited. And also in our healthy volunteer studies, many of them said they felt better and they felt more enlivened and more in touch with the world afterwards. So we wrote the grant. Amazingly, it got funded. I mean, so it was a 3-year grant. It took 30 months to get the psilocybin. Only one place in the world could make it. It wasn't in Britain. 30 months.
So you had 6 months left to do the work.
Well, hang on. And then 2 more months to get permission. So we had 4 months. And then I wrote to the MRC, so, can we extend? And they said, well, but eventually they wouldn't give me any more money, but we carried on going. We got charitable money. But what a waste of time. Nearly 3 years. Now it's only a year, so we've made progress, but it's still super.
Yeah, I mean, we're laughing not because it's funny.
No. It's
because of the sheer absurdity.
Absurdity, exactly.
Why do we bother with consultant psychiatrists if we're not going to listen to them? It just seems.
Well,
anyway.
Oh, John, let's not go. But part of the challenge is that successive governments have tried to destroy the ability of doctors and nurses to think. We're not allowed to think. We have to do. We have to do what someone tells us, and that's NICE or that's the MHRA. If one day I'm going to write maybe the last paper I'll write will be a call to arms to doctors to start thinking again, rather than just basically working through algorithms which are wrong.
Yeah, sounds rather dangerous. I actually worked in full-time academia and education for nearly 30 years, and when I retired, I went back as a staff nurse on A&E. Just part-time. It was great. And, it's very much then a patient would come in, and it wasn't the doctor thinking, oh, let's think about this. It was, oh, go away and find the protocol for this. Go away and find the NICE guideline for this. It was all based on protocols, tick boxes, what it says in the BNF, what it says in the NICE guidelines. There didn't seem to be any application of what maybe we used to call a medical opinion.
Yes, no, you're right. I often say to people, I often think now, if I discovered penicillin today,
yeah,
I would never be able to try it. I mean, I would have to spend many millions of pounds before I could even know it worked. Whereas, obviously, when it was discovered, and then made by Shane and Flory in Oxford, there was a policeman dying of staphylococcus, and they said, well, let's give it a go because it kills it in the chest tube. Yeah. And a whole new branch of medicine, antibiotics, was developed. But today, you couldn't do that. You wouldn't be allowed to. You're not allowed to be innovative at all. It's really disappointing.
Absolutely. Well, the discovery of insulin, they went along to a ward and saved a child's life straight away.
Yeah. Absolutely. Now, if you did that now, they'd strike you off.
Yeah. So, psilocybin's potentially useful in depression, anxiety, addiction, anorexia nervosa, potentially, post-traumatic stress disorder, which is common. I mean, maybe we can't do all of those, but maybe just focus down on addiction. When I was 18, I remember, I won't tell you the names, but I remember the first 2 or 3 alcoholics I looked after. One of the first guys I looked after, and we got quite close relationships with these guys in those days. And I said to one guy, I'm sure he wouldn't mind me using his name. I know he wouldn't. I won't use it, but we'll call him Brian. But I said, Brian, when did you start drinking? At this stage, you'd be about 27, hopeless alcoholic. Mm-hmm. He said, well, John, I started when I was 19. I said, well, that's quite late. Yeah. He said, well, yes, at home we didn't drink. It was a fairly religious household. They didn't drink at all. He went to university. First day at university, went to a party, had a few drinks, got drunk. And then he said to me, but I tell you what, John, I was drunk again the day after. And from that point, I think he was an alcoholic, and he died when he was about 29. And, several cases like that I remember well. And, the idea that we could have treated their addiction, is that fantasy, or do you think these things could have really saved these young men's lives?
Well, the answer is it could have done. So in the 1950s and early 60s, there were 6 trials of LSD in alcoholism. And basically they were putting people through an abstinence-based program, trying to stop them drinking. And some of them, half of them or roughly, got one LSD treatment and the other half didn't. And that data was kind of repressed and forgotten, but and denied because of the ban. But about 10 years ago, 2 Norwegians went back and they actually got the source data, which was quite remarkable. And then they analysed it and they showed, well, LSD actually, in those trials, had what we call an effect size, in terms of the impact it had on the disorder, which is 3 times greater than any subsequent treatment we've had. And if you so you think, hang on, so that was done in the 1960s. So let's say 1970 LSD was banned, and we're now what are we? We're 55 years on, right?
A couple of generations, yeah.
I've done a sort of back of the envelope calculation. So probably on average, at least now it's 3.5 million a year, but maybe back in the 70s it was. So say it's 2 million a year people who've died prematurely, like your patient from alcoholism. So what's that? That's 120 million people have died prematurely. How many lives have been saved by banning LSD? Well, probably none, but 1,000, 1 million. The point is, the equation is so much in favour of the utility of it that it's utterly outrageous that it's been banned, and it didn't need to be. They didn't ban morphine because people were using it, but they banned LSD because it was making people vote against the war.
Yeah, and again, I can't condone this because it's a Class A drug, but I've come across people recently who are addicted to alcohol and cocaine.
Yeah.
Joint addiction in the same person, and they are completely off cocaine and have a couple of beers at the weekend, the same as most other people do.
It's a very interesting thing you point out that's really important, John, because people say, well, it can't be right. You only give one treatment and they're better. And how can that be? Because we've been so conditioned to the model, you've got to take pills every day. So it's very difficult. It's very difficult to get the truth. What were the drivers for the ban? Now, my personal belief, it was largely political, but I think there was also another element. As the modern pharmaceutical model began to be developed in the early 1960s with imipramine and chlorpromazine, and of course that is a phenomenal economic model if you're selling a drug, because you take the drug every day. Whereas with psychedelics, you might just take it once in your life. And I think there was quite a bit of pressure from the pharma industry. Certainly the pharma industry didn't oppose the ban, let's put it that way.
I'm reminded of the Helicobacter pylori situation where
Yes.
Tom Brodie and Barry Marshall in Australia came up with this ludicrous idea that peptic ulcers are caused by a bacteria, where everyone knows they're caused by whatever it is, stress or whatever. And at the time, I think the pharmaceutical industry at the time, from memory, was selling $9 billion a year. And this must be in the early 90s. So $9 billion a year in the early 90s is a lot of money of H2 blockers and later proton pump inhibitors. And they weren't very keen on curing a condition.
No.
And the analogy is there, because with a Helicobacter pylori eradication, you treat it for a couple of weeks.
I think it's a
great
better. I think that's a great, and the way those guys really had to slave away to get anyone to take any notice. Yes.
Well, there was self-experimentation involved. Barry Marshall took it and took the Helicobacter. So, not that we're advocating that, but there are self-experimenters around that we know.
Yes.
Depression and anxiety, is it? What kind of results are you getting?
Well, I think it's certainly psilocybin in the modern era is probably the most powerful treatment of resistant depression we have. Yeah. It's actually staggering how effective it is. And people might say, well, hang on a second, you're talking, how can you cure addiction to alcohol, to cocaine, to heroin and depression? They're completely different diagnoses. And the answer is, well, they are different diagnoses. In fact, they actually come from different parts of the brain, the drives and the memories and the behaviors. But the reason psychedelics can work across these different disorders is because they change the way people think. the disorders psychedelics work in are what we call internalizing disorders. They're all disorders in which people have thought processes which they can't escape from. Very often, they know that their thoughts are wrong. I mean, maybe you're alcoholic, I mean, certainly many of mine over the years. They don't want to drink. They don't even enjoy drinking, but they can't stop. And they, depressed people, mostly they know they're not worthless. They know they've been traumatized. It's not their fault, but their brain keeps thinking it is their thought. And those deeply entrenched thought processes, in fact, the only things we know of that can break those deep thoughts are psychedelics.
Yeah. So you've actually got models of what's going on in the brain. I mean, you mentioned GABA at the start of it. I mean, the GABA's the GABA amino butyric acid from memory, the diazepam and the benzodiazepines work on. Yeah. And you've mentioned 80 other transmitters, which is quite incredible. I mean, do you have? I know you have quite modern, sophisticated scanning techniques and understanding of the biochemistry. Are there plausible mechanisms that you can now understand and give evidence for how the psychedelics are working?
Yeah, probably I could give you a better explanation. Sorry, not better. I could give you a better evidenced explanation as to why psychedelics work than I could for how SSRIs work. Right. And that's that's been one of our ambitions. Because people say, well, okay, so you can lift depression with psychedelics, but you can lift depression with lots of other things, CTs, SSRIs, tricyclics. And about 15 years ago, we started thinking, well, are we actually doing just the same but faster, or are we doing something different? So we set out to specifically use brain imaging to test that question. And it's absolutely clear that there are fundamental differences in the way these drugs work. And as I've already mentioned, what psychedelics do is they disrupt ruminative, ingrained thought processes, which keep people thinking the wrong thoughts. What SSRIs do, and this is, we've shown this very clearly, is that SSRIs work in a different part of the brain. So psychedelics work in the cortex, the very high level thinking parts of the brain, the parts of the brain that are just behind here, where we are
the very human part of the brain.
Exactly, the bits of the brain which is where all the human self-awareness and analytical and communicative skills exist. Whereas antidepressants work deep in the brain. They work at a more primitive level. They work in what's called the limbic system, the stress circuit. And what they do is they dampen down stress responses. And the analogy I like to use is this, is that drugs like SSRIs are to depression what a plaster of Paris is to a broken bone. The plaster of Paris doesn't heal the bone, but it allows the bone to heal because it stops the bone moving. SSRIs dampen down the stress centers in the brain and allow the brain to recover from the chronic stress, which has actually damaged them to some extent. But the problem with that is that SSRIs don't just dampen down stress, they also dampen down the positive emotions, because these are the emotional centers. They're not just stress centers, they're the emotional centers. So people on SSRI sometimes say, well, yeah, I don't feel the stress anymore. I can watch TV and see people being hurt on TV without getting those emotional reactions. But I'm not as positive. I don't get as much pleasure out of life. I'm not as interested in food. I'm not as generally. I have a more narrow repertoire of emotions. And for some people, that is, rather, it's disappointing. Well, for anyone, it's disappointing. But for some people, it means that they don't want to stay on the medication. And we've shown clearly now that psilocybin doesn't do that. Psilocybin has no impact at all on the emotional center. You can still have full range of emotions, but not be depressed.
Mm. And of course, a full range of emotions is intrinsic to what it means to be human as well, isn't it?
Well, yes, absolutely. Most of us want, particularly the good ones.
I could do without some of them, yeah. But I was when you said ruminative disorders there, the idea of the ruminant who keeps chewing the cud.
That is exactly.
You know, the idea it goes into the stomach and you come back up and you chew it and it goes back down and it comes up and you chew it some more. You know, who watching can't relate to that? Get these ideas out of my head. I don't want to be thinking about this anymore. I don't want to think in these terms anymore. And yet,
It's
for years and decades...
Because your brain is one of the problem with the brain is, you know, the strength of the brain and the weakness of the brain. Your brain is an amazing learning machine. You know, we have been talking for nearly an hour now. We've used thousands of words, and you've understood every single word. You know what every word means. You might not have understood all the concepts, but you probably have as well. But the fact is, we can learn words to a precision that means fantastic at learning. But if you learn the wrong thing, if you learn that thought, oh, maybe I left the tap on, and you can't stop thinking that thought, then it consumes you, and that's the problem.
The amount of times I've got to the car and gone back to check the front door when I know I've shut it.
Well,
that just happens all the time.
The good news, John, is that you've got to make the diagnosis of OCD. You've got to do it 3 times. All right. Okay,
right. So that's very encouraging. Thank you.
Can I just say a little bit more though about the imaging?
Yep. Please. Oh yeah, it's a fascinating area.
So I think perhaps the most amazing thing we've discovered is not that how psychedelics work in the brain. It's not that we can treat depression with psychedelics. Is that when we do treat depression with psychedelics and we image the brains of people after they've recovered from their depression and we ask them how they feel, they say, well, yeah, I feel like my brain works more flexibly. I'm able, when a negative thought comes in, I'm able to push it to one side and change my direction of thinking. My thoughts are more flexible. And when we scan their brains are more flexible. And that to my mind is, it's almost, it's almost too good to be true, but it is. People's brains are more flexible after they've taken psychedelics, and that is why that's why they have such enduring effects. Because if you've got a more flexible brain, you can solve problems. Mm-hmm. It's more creative. You're more, and also you're more in. You can look outside of yourself. Because there's brain imaging studies that show depressed people consume so much more of their brain thinking about themselves than non-depressed people. Mm. And that means they haven't got the brain resources to do other things, like engage with nature or engage with friends, think about other things.
Mm. Amazing that you can see the sort of neurophysiological activity, and if you like, the I was going to say the behavioural correlates of that, but it's not really that. It's the human experience of that.
Yes.
The human perception of that.
Exactly. It is. I hope it gets replicated, but we've replicated it twice in 2 separate cohorts of depressed people. I need another group to do it to make sure it's true. But it's wonderful. It was wonderful to see people who have escaped from this, the chains of depression, which are absolutely, we know they're destructive. 15% of people with severe depression commit suicide. It's an evil disorder, and it's lovely to see them liberated. Yeah.
It's possible to feel wretched beyond description. Hopefully we'll never fully understand how bad depression can be, but
hope
even just being around the edges of it's pretty bad. Now, one of the questions in my mind, David, is that, okay, you can give a relatively large psychedelic dose of, say, psilocybin or LSD, and you have a particular experience. Now, the question in my mind is it the experience, or is it the pharmacodynamic effect on the brain? And what argues, in my mind, in favour of the pharmacodynamic effect rather than the experiential effect is that microdosing can be effective.
Okay, so that's I don't know quite what your audience is, but I imagine some of them won't understand. Well, they all understand pharmacodynamic.
I've got them fairly well trained up.
Okay,
I'm quite strict. So we're just talking about the way that medicines work on the body, the way they affect the body. Yeah.
So that is a big question you've asked, right? Because you've asked 2 questions. You've asked, is the pharmacodynamic effect, and is a lower pharmacodynamic effect through microdosing, could it be effective?
Yeah.
And the answer is both are true. So but in terms of the big trip, and there's a huge debate going on at present, and I'm going to tell you where I stand, and I think you'll probably agree with me. I actually think that the lifting someone out of depression with a powerful trip is likely to have some psychological effects as well as just being a biological effect of the brain.
Sure.
Now that's what we know from history of treating depression with other drugs that if you engage in therapy with medicine, you get better outcomes. So it's kind of, to me, that's what psychiatry is. It's not just giving people things; it's actually helping them overcome their stress and their distress by therapy. So I believe in that. I think it's ethical and morally right. But as you're probably going to guess, there are companies being developed which say, no, we don't want to do any of that because we don't want to waste our time talking to people. We just want to give them a jolt, shake their brain up, and then we'll get better. And I say, well, that kind of surely there must still be value in talking. You say, well, we can't do the talking because if we do the talking, the FDA won't approve us.
No, we're limited in what we can say, I know.
Exactly.
But there is evidence, you're fairly convinced that microdosing can be beneficial, can be therapeutic.
Well, it's a different kind of therapy, so this is really important.
Right.
Microdosing, yeah. Taking a microdose of a mushroom today isn't going to lift your depression.
No.
But
it will take weeks.
Over time, I think it's, certainly there's plenty of sensible people who, I respect, who have used microdosing to benefit. But proving that microdosing works is challenging, partly because it's the illegality means it's almost impossibly expensive to do the studies. I think it's plausible. One of the things I'm quite interested in is, because so many people tell me that microdosing does help them, I can't prove it, but it's perfectly possible that after a trip, you might be able to maintain wellness or even improve wellness with microdosing. That's a study that needs to be done, but very difficult. Because can I just tell you, here's an anecdote, this is a true story. 7 years ago, working with Amanda Fielding at the Beckley Foundation, we got permission to do a LSD microdosing study at Imperial College. But, they said, every microdose had to be given in hospital. And we said, well, it's a microdose, they're not... And they said, well, yeah, but it's an illegal drug and, we can't have them walking around the streets with it. And we said, well, we can't do that because that means bringing everyone in at least 2 days a week for 6... We can't afford it. And they said, tough. And so we never did the study. So it's much harder, paradoxically, to do microdosing studies than it is to do what we call a macrodose. Yeah.
No, absolutely incredible. So when you take a large dose, a macrodose, you're going to get this acute trip psychedelic effect.
Yes.
And presumably you get some ongoing biochemical effect as well as that. So in a sense, I think what you're saying is you can synergize the neurotransmitter effect and the neurobiological effect with the psychological experience.
Yeah, and there are two separate biological processes, which I think you're kind of alluding to. The first is the trip, and the second is after the trip. As a result of the pharmacodynamic interaction in the brain is more able to think differently. We call it neuroplasticity, and it lasts for weeks. And that allows people to opt to really get maximal benefit from any kind of talking therapy.
Yes. This is another thing that's come out from your book, the importance of the talking therapy, the psychotherapy, the counselling, the drug, the trip, the experience, facilitating increased plasticity, and then moulding it, striking when the iron's hot. Really,
that's a good analogy. That's a very good. In fact, yes, that's an excellent analogy. Yes. What's that term they use? We use this. What is it when you take a metal and you stick it into water? So
tempering.
Temper it, and like anneal. Yeah, that's right. That's exactly the analogy. Well done.
Yeah, and then hopefully you get a nice, firm, crystalline structure to extend the analogy in the metal that perpetuates for life.
And you can't break it. You can't. Those depressive thoughts can't get into it because you've got the right, positive thing.
Exactly. I think, for me personally, I don't know. You might get a few people saying this that. To be quite honest, I haven't done much with different drugs, but There was a time I tried some. I don't know what I'm allowed to say on air, but overseas where it was legal, I did once try some cannabis.
Oh, right.
Because I thought it might help with my mental state,
Uh-huh.
and not a lot, a small dose. And I must say, I absolutely hated it. I was really struggling to maintain my contact with reality. I felt like this thing was like putting me below the water, and I thought, no, I want to be in the real world. So for someone as obstreperous as me, if you gave me if I was in one of your trials, you gave me a psychedelic dose of psilocybin, I think I would really struggle to go with it. I think I'd probably be fighting it and trying maintaining contact with reality. Does that make sense, what I've said?
Well, I think a lot of people are like you. So I think I would say several things. The first is we would never make someone take a psychedelic.
Oh, heck no.
Because that was done. That was one of the ways in which they discredited psychedelics. So there was, in order to get rid of psychedelics, they paid senior psychiatrists in the States to do experiments, like where they chained patients to the bed and they gave them LSD and they said, look, it doesn't work. I mean, disgusting. And apparently that got a prize for the best study of the year in like a sort of.
It's just a complete inversion of everything that medicine stands for, isn't it?
Absolutely. So people they must consent. But even when people consent, many of them are like, they're anxious because they've never had it before. All the stories, we've had 50 years of people telling us you'll go mad if you take LSD. In fact,
you jump off high buildings, you'll peel your skin off because you think you're an orange.
Exactly. And in fact, we know, the press, anti-LSD press that was put out at the time of the ban led to a very significant increase in the adverse effects of LSD because people were taking it and then, oh my God, I am going to go mad. So, you can create by basically dishonesty, you can create fears in people which become self-perpetuating to some extent. So what we do in our therapy, and this is really critical, is we spend several hours the day before people have their trip preparing them for this. Right. And you're quite resisting it. You can resist an awful lot. You can, if you really try hard, you can almost certainly not get any benefit. In fact, then you just get perhaps some distress. Yeah. Our motto is, go through, let it go through, and then you go to into states of where you've been in the past, and you relive aspects of your life in childhood, and then you get benefit. But so the reason we encourage people to, the way we help people have the courage to go with it is by having the therapist there all the time.
Yeah, I guess there were, I've had people like you around and experienced doctors and therapists that understood that.
Yes,
it might be possible, but I just consider myself a rather poor candidate because I tend to fight things. It's a pity.
Well, you're right. I think you're right. It is. It would be a pity. But you may not need it. So let's hope you do.
Yeah. So. Again, it's not hard to find people that have had experiences. I've met people, talked to people that have had incredible experiences. They've met entities.
Yeah.
They've been to other realms. What I'm trying to ask here is how do we understand this overlap with spirituality and spiritual religious type experiences?
Well, I think they're one and the same. I mean, I don't know if I told you before, but I gave a talk in the Vatican about a year ago.
No, you didn't.
I gave a talk on psychedelics in the Vatican, and in fact, it's come up. It's online now. You can go online and you can see my Vatican talk. And I start off by saying that almost all religions originated from experiences which either derive directly from psychedelics or other ways of changing your brain, like starvation, like sleep deprivation, like dehydration. So psychedelics are just a very efficient way of allowing you to achieve a spiritual experience.
I suppose there is counter-argument there, though, that if you assume that we are created, whether that was quickly or through an evolutionary process, and God wanted to communicate with people, he'd have to have some apparatus to allow a spiritual experience while in the flesh. It kind of, you could argue it both ways.
Yeah, but why would he make it so hard?
I'll ask him when I see him. I'm not
okay.
sure.
Well, if you've got this, yes, please, and then give me the feedback. I mean, on a serious note, I mean, two important things about that. You know, there's even a science of this. If you read in the book about the Marsh Chapel experiment, there was a study done in which people were given psilocybin. These were priests, novice priests, who were given on Good Friday. You know, when they had 6 or 7 hours in the chapel thinking about the crucifixion. Half were given psilocybin, half were given a placebo, active placebo, and I think 9 of the 10 that got psilocybin had a powerful religious experience. They understood what it was like, to be in touch with God, which is, of course, when most people talk about religious beliefs and desires, what they really are saying is they want to have that experience of being with God. Most people are seeking it; they don't make it. The psychedelics can help them, and as a sort of follow-up to that, there's a little study going on in America now for priests who've lost faith, and seeing whether psychedelics can help them regain their faith.
Interesting. I've just got these spectacular rays of sun coming through my window at the moment. So
you do rather, yes.
It's creating a heavenly effect on
as long as you're not going to be, it's not going to be
on the video. As long as you can see it as well, that's the main thing.
I can certainly see it. I'm just very envious. There's not much sun here.
Yeah. But it's sunny every day in Carlisle, if only.
Are you still there?
Yeah.
Do you know something?
Yeah.
You're about to get to medical school. Imperial College is about to...
No, we are. The Pear School of Medicine.
There you go.
Yes. I've been away for a few years, but this is where I've drifted back.
You might even get me up there lecturing to your medical students.
Yeah, they never know. I might be invited to give the odd talk.
Absolutely, you
it's
should.
It's not impossible, actually. Yeah, I've got a few friends who are teaching on it.
Has it started?
Well, I don't know if it. I think they were recruiting the first. They've either just recruited the first group or they're just about to. But I know I've got some friends who've been appointed to positions.
How excellent! Okay, so it's going to be a sort of community-based medical school, bro.
I think so. Yeah, sounds good. Have you got time for a couple more, David, or do you need to get away?
Yeah, no, maybe another 5. Yeah.
What precautions and supervisions do you take when people are having psychedelic experiences in the trials that you conduct?
No, that's a hugely important question. So, the first thing is we exclude people who have been psychotic, are psychotic, or who've got close family members who are psychotic. Because although there is a bit of evidence, some people say, well, psychedelics have helped their psychosis, there is also evidence that it can make it worse. So we're very, very conscious of not wanting to make things worse.
Could it actually induce psychosis in someone who wasn't psychotic?
Well, the experience is like psychosis in a way. I mean,
it's temporary. That's the point.
That is the point. So then, is there any evidence it having? If you are predisposed to psychosis, if you're on that trajectory because of either genetics or other things, then it might do. I have very, very few cases of that. Normally, but if you are psychotic, it can make it worse.
Yeah. I interrupted.
No. And then the second thing is we obviously have to make sure we don't give it to people who are going to have bad effects, and particularly with psilocybin, we're not so clear about the others, but because there's less work. If you're on, for instance, lithium, that can be quite dangerous because it can have seizures. And then there are other drugs which are quite common drugs like olanzapine, risperidone, mirtazapine, lamotrigine that block the effects. So there's no point in really having them.
You wouldn't get the effect, yeah. If someone's having a bad experience, is it true that it can be reversed with phenothiazines and benzodiazepines?
Yeah, that's our experience. Absolutely. Yeah, you could. I mean, obviously, you can terminate a trip very easily.
With diazepam, for example.
Yes, not in any other clinical, not in any of our clinical studies, but in the big LSD study we did when we were giving people LSD and they were in a scanner on and off for several hours. Someone did get really quite claustrophobic and got quite paranoid, and we gave them a benzodiazepine to calm him down, and it worked. It was but the bigger problem is not stopping the trip. The bigger problem is, do they have enduring distress because they don't forget what was going on. And
yes.
He was interesting because he wrote about it, saying, "Yeah, I actually didn't enjoy the trip, which is why I got out the scanner." And I would just say to people, we never ever scan patients during a trip, never, because that would be unethical. Anyway, we want to maximise the value. And those of you who've been in a brain MRI scanner know it's pretty unpleasant.
Well, any MRI scan, I've had one from a prostate. It's a very loud, noisy tube.
Yeah, exactly. It's not a place you want to be. But even he said he got insights, and this is a big
interesting.
When I first started doing this work, we published the first paper nearly 10 years ago. Senior colleagues said, "Well, David, of course they're getting better because these depressed people are getting better because you're giving them a fun trip," and that's exactly wrong. Almost none of them have. We prepare people. They're going to be very challenging because they'll very often go back and they will see things in their past that explain why they're depressed. They're horrible things, they're nasty things, often they're traumatized by other people, but they can deal with them. They can deal with them in the trip. And then when they come out, they're kind of healed, or at least on the way to heal.
Another sort of concern I have is that we've got this idea that psychedelics can almost remodel the parts of the cortex of the brain. I mean, if I took psychedelics and had profound experience and my brain was remodeled, am I still the same person after that? Because a lot of what I am as a person is comes out of my neurological architecture.
Yes, well, that is a very profound question, and the truth is you aren't quite the same person, but hopefully you're more the person you wanted to be.
Right, that's interesting. Yeah. Or the person I should be.
Well, it depends who says should, but as long as it's your ego telling you what you should be, yes.
It's almost like a pain, I mean, or a classic example is, I've had the, I would say, enjoyment of cleaning people's ears who've been deaf for months. And they go away and they put their olive oil in, and then you syringe the ears very gently, and you get this beautiful big lump of horrible earwax out.
Yeah.
And they say, "Oh, I can hear."
It's wonderful.
They forgot what it was like to be normal.
So the analogy I prefer to earwax is cataract operations.
Yes.
Because
much better, yes.
Having had them,
yeah,
it is like the scales fall from your eyes, and that's what psychedelics do. The scales, you suddenly see yourself, you see your true self, and you realise that a lot of the things you've been doing, you probably, are a bit regretful about, and actually,
tell me about it.
You didn't realise you had bad. So it's rare for people not to come out as what you would call better people, more insightful, more caring, more humble.
Do you think there's reduced incidents of violence and aggression in people that have had psychedelic experiences?
Well, there's definitely evidence that people who have had psychedelic experience have less mental illness. And there's also a couple of interesting studies from the States which take prisoners who, having left prison, then have a psychedelic experience, are less likely to go back into prison. So it may well help people deal with whatever it was, with the anger, the violence, the distress that leads them to commit crimes. So population terms, psychedelics do seem to be healing.
Interesting. So I was in Australia last April, and I was talking to a couple of psychiatrists there, and they have just been given permission to start prescribing psilocybin in Australia. So I don't know how that's going now, but that must be a great opportunity to collect prospective data
Indeed.
on various doses and efficacy.
Well, they're all going to use the same dose. They're all going to use 25 milligrams of psilocybin.
Oh, that's right, okay.
Or 100 milligrams of MDMA, because it's a standard dose. It can only be brought in those doses effectively. But no, it's a wonderful. I'm so pleased with Australia for two reasons. The first is the first country in the world that actually has accepted the reality that psilocybin is a medicine for treatment-resistant depression. And whereas we in Britain say, oh, we need clinical trials, the Australians said, well, there's 1,000 patients already been treated in the last 10 years. Well, why do you want a drug company to tell you it works? Because it does work. You know, we're the experts. We're the assessors. We're not going to wait until some company sells psilocybin to us. We're going to approve it and we're going to make it available. But the clever thing about Australia, and was that there was a charity, My Medicine Australia, available to provide the training and the medicine. And so this is a completely new model of psychiatric mental illness treatment. And I think it's a brilliant model, and I would like to see it rolled out in other countries all around the world. Why should we have drug companies making profits out of people's distress when we've got treatments which we could make available today without profit?
And as the drugs are used, it essentially becomes a post-release clinical trial, doesn't it?
It does.
That's stage 4 clinical trial where we can collect mega data.
Exactly, it's real-world evidence, and I'm on the monitoring board for the Australian.
Interesting.
And I think, and I'm hoping that, and we've already got quite a bit of data now from Australia, maybe I think over 150 patients. In Switzerland, they've had a compassionate use now for quite a few years, and they've got several thousand patients. There is a database there which should make any country accept the validity, certainly, of psilocybin.
And yet we are. I mean, there's no prospect of generic GPs or even psychiatrists being allowed to compassionately prescribe in the UK, as far as I'm aware.
Well, we're pushing. John, we never stop. It's one of our big ambitions now is to change the scheduling, because that's what they did in Australia. They just said, no, take it out of Schedule 1, or their equivalent, which was Schedule 9. Yeah? It's not addictive, it's not dangerous, and it does work. So how can you justify keeping it in Schedule 9? We've been saying that to the government now for several years. Explain to us why psilocybin, which was a medicine in the 1950s and 60s, which we know is safe because with thousands of patients now around the world given it, explain to us why it's still in Schedule 1. And they don't answer. They don't. I mean, they don't. They do. I think. I think maybe we're going to have to go into some parliamentary question. It's outrageous that the government will not revisit the scheduling of these drugs when people are. So many people are suffering from mental illness.
And to be clear, what we're advocating for is doctors and nurse practitioners to prescribe this. Maybe psychotherapists in some occasions.
Exactly.
We're not talking about legalizing this for generic recreational use. We want doctors to be free to be doctors.
Well, this is the real stupidity of the situation, because we know in Britain, you've told me already, some of your colleagues or people here, we know that 500,000 people a year in Britain are using magic mushrooms. They're not dropping dead. No, they're not. We don't need recreational. It's there. So, but why adopt? The people that really need it are we're not. It's exactly the inverse of how it should be.
Yeah, and medically, I mean, of course, you could get the wrong mushroom and die. We would counsel strongly against people ever trying anything like that without full medical supervision. There are some poisonous mushrooms, which is really quite dangerous. But
yes, I was.
The fact is, these are being widely used, but we're advocating for doctors being allowed to prescribe them, not for people being able to take them. Well, but medically, if it's pure psilocybin and you get the right magic mushroom, is there any particular physiological medical risks?
Oh, well, I mean, obviously, as a recreational user, you can't get psilocybin. You've got to use mushrooms.
Yeah.
Yeah, so the risk is getting the wrong mushroom, but that's
Yeah.
I mean, unless you're really silly, stupid.
Whatever you do, if you're watching this video, do not take mushrooms. Do not take anything based on what we're saying. This is an academic discussion.
But there is an interesting question, and could mushroom juice, which contains a lot more than psilocybin, could that be better than psilocybin? Now, I get emails on a relatively regular basis saying it is better than psilocybin, in the same way as whole plant extract cannabis is better than THC. And I'm open-minded about that, but it's impossible for us to study because, do you know, in Britain, John, you may not know this, in Britain we do not have a single herbal medicine approved on the BNF. We don't, because we don't believe in herbal medicines. Why not? I don't. I sat on the Committee on Safety Medicines when German company tried to bring St. John's wort through. The data was perfectly compatible. It works. It's not very strong, but it's definitely got a signal in terms of mood and anxiety. And the committee rejected it, and I was supporting it, but it's a vote. The committee banned it on the grounds that they couldn't absolutely guarantee the exact amount of the active ingredient in each of the herbal pills. And
of course, there are plenty of legal mushrooms that people can take. I mean, for example, I've got a friend whose life was transformed with tincture of lion's mane for post-concussive disorder. You know, the evidence that stimulated axonal regeneration, to my mind, is strong. Again, we're not advocating anything in particular, but we're just missing so many tricks. Totally.
As we said at the very beginning, we're not allowed to think.
David, that's fantastic. I've kept you going I have got more questions, but I don't want to keep you all day. I know you're busy.
I need to do something with my wife in a minute. So
I just have one last one. You've developed a new drink. What is it?
Oh, well, yes, I've been putting my mind to helping people avoid drinking alcohol, and it's called Sentia, and it's a herbal drink. There's all food approved herbs, which mimics the relaxing sociability effects of alcohol, but will not give you all the problems of intoxication and addiction and aggression and hangover. So it's a way of helping people, using psychopharmacology, really, herbal psychopharmacology, to help people escape from the harms of alcohol.
It's about time someone invented a new drink. We've been using alcohol since the days of Noah, after he came out of the ark and planted a vineyard. And
indeed,
you know,
even before
you think, even before that, you think humankind could come up with some new drink. So is Sentia with a C?
No, scent.
Scent, right.
Sentias.
Right.
It's the Italian for sensation, but I don't know. I didn't invent it.
Interesting. Thank you so much.
John, if you ever want a conversation about alcohol, we can do it again, all right?
Oh, I've got another book that you wrote here as well.
Yes, it's the drinks book.
No, it's the cannabis one.
Oh, right. Okay.
Yeah,
we can talk about cannabis.
And I'd love to talk to you about research and the ludicrous situation with the preposterous inhibitions of the pharmaceutical industry controlled randomized double-blind controlled trial system and all many other things. But
well, anytime. All right. Lovely to talk to you.
If you've got to the end of this video, well done. It's an hour and 23 minutes. But Professor, thank you so much.
Thank you, John.
Thank you.